What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my neurology playlist. In previous videos, we talked about strokes, ischemic and hemorrhagic. We talked about the different types of shock, including neurogenic shock. We discussed the Glasgow Coma Scale and the levels of consciousness. We talked about the Cushing reflex or the Cushing triad. We talked about the role of dopamine in the brain and the different dopaminergic pathways. And we talked about multiple sclerosis, Guillain-Barré syndrome, Lambert-Eaton myasthenic syndrome, and myasthenia gravis. Today, let's talk about brain herniation, which can happen because of increased intracranial pressure, also known as intracranial hypertension. What does herniation mean? Is to bulge outside your place, to ooze out, so to speak, which can lead to many unfortunate consequences. Click the like button, click the subscribe button, and let's get started. I have two playlists for neuro. One is neuroanatomy, the other is neurology, which has everything. It has neuroanatomy, neurophysiology, neuropharmacology, and neuropathology, and internal medicine, of course. Of course, you know that your nervous system is made of central nervous system and peripheral nervous system. The central nervous system is made of two things and two things only, brain and spinal cord. As for the peripheral nervous system, it's what's coming out of the brain, which means cranial nerves, and what's coming out of the spinal cord, which means spinal nerves. Let's talk about the brain, which is part of the central nervous system. The brain is made of three parts. This is the forebrain. The midbrain is hidden about here. And this is the hindbrain. The hindbrain is made of pons, medulla, and cerebellum. As for the forebrain, it is the cerebrum and the basal ganglia. The cerebrum or the cerebral cortex has frontal lobe, parietal lobe, occipital lobe, temporal lobe. The brain is located inside your skull. And according to the Monroe-Kellie hypothesis, which is the dearest hypothesis to my heart, it says that the skull is like a box that is 100% full. It is packed and stacked and stuffed. There is not a single inch of empty space in that box. So therefore, anything new that arises inside that box has to raise the pressure.
But hey, Medicosis, I'm a 23-year-old.
Nice to meet you.
Is it possible, all things being equal, for a tumor to arise in my brain while my intracranial pressure fails to rise?
It's impossible, c'est impossible. If a tumor arises in your brain, the intracranial pressure has to go up because your skull is 100% full. So anything that adds will add up pressure. And this increased pressure will lead to, well, something has to give. Herniation can happen. And this is the straw that broke the camel's back. So any brain tumor, forget tumors, any brain abscess, any space-occupying lesion in the brain, or trauma can raise the intracranial pressure. Raising the intracranial pressure increases the risk of herniation, but decreases cerebral perfusion pressure. What does that mean? Well, I want you to imagine that there is an artery going to supply your brain. Think of the vertebral artery, for example. And this doozy artery wants to supply your brain with arterial blood. But if I have a brain tumor, what's going to happen? Well, the intracranial pressure will rise, and this pressure will press on that poor artery and squeeze that artery into oblivion. So the artery gets narrower and the flow gets poorer because the artery is being suffocated. And this decreases cerebral perfusion pressure. Moreover, increased intracranial pressure can lead to Cushing reflex or Cushing triad, not to be confused with Cushing syndrome. If you want to learn more about Cushing reflex, I have a special video on this topic. You can find it in my neurology playlist. What is the name of this doozy foramen in the skull? Foramen magnum, the big foramen. By the way, if you want anatomy review on all the topics of anatomy, please check out my anatomy playlist. I have anatomy quick review for the abdomen, anatomy quick review for the pelvis and perineum, for the upper extremities, lower extremities, head and neck, and even neuroanatomy and embryology. Each subject is summarized in just 2 videos that are out of this world. Just search YouTube for Medicosis Anatomy Playlist and you will find it. Now let's talk briefly about the sequelae of brain trauma, or why you, as a doctor, should never run around punching people in the face. Consequences of brain trauma include brain swelling, brain edema, increased intracranial pressure, which can lead to brain herniation, which is today's topic. It can lead to Cushing reflex or the Cushing triad, which is a triad of hypertension, bradycardia, irregular breathing. Any patient with hypertension, bradycardia, irregular breathing has high intracranial pressure until proven otherwise. Never ever forget that. Hypoxia or ischemia, because increased intracranial pressure will lead to what? It will lead to decrease the cerebral perfusion pressure. Trauma can lead to fractures. Fractures can introduce bacterial infections. The increased intracranial pressure can also lead to headache that happens to be frontal headache that is worse in the morning and worse when I lean forwards. Vomiting, not any type of vomiting, but projectile vomiting. It reaches the roof of the house. I'm exaggerating slightly. I want you to look deep into your patient's eye, to the retinae. You'll find papilledema. The patient will complain of blurry vision. If you do lumbar puncture, there is increased opening pressure. But be careful, if the intracranial pressure is so high, let's say there is a brain tumor inside, if you actually perform a lumbar puncture, this can cause herniation. Again, think of the box analogy, and there was a tumor inside the brain, and here is you taking fluid out of the CSF via lumbar puncture. Oh! You can trigger part of the brain to bulge outwards like this, and this is what we call herniation. Intracranial hypertension can lead to altered consciousness, can lead to midline shift on neuroimaging. Do you remember my video on cerebral abscess? What did we say? We said that a brain abscess is a space-occupying lesion which can increase the intracranial pressure in your brain or in your skull, which can lead to morning frontal headache, projectile vomiting, papilledema, blurry vision, increased opening pressure, brain herniation, Cushing reflex, decreased cerebral perfusion pressure, which can lead to hypoxia or ischemia. If you want to see more videos like this in the future, please drop a brain emoji in the comments. So now you know about the consequences of high intracranial pressure. Let's add to them macrocephaly in an infant, because the infant's skull sutures have not fused yet. So therefore the baby's skull can bulge and literally get bigger, and this is macrocephaly. Cephalo means brain or cranium or skull, macro means big. If you want to see a very scary picture, use your search engine and look for a picture of hydrocephalus. This word right here. So these are the consequences of high intracranial pressure. But what causes high intracranial pressure could be idiopathic intracranial hypertension, otherwise known as pseudo-tumor cerebri, where there is no tumor. Brain abscess is a space-occupying lesion. Hematoma, same idea. Brain tumor, same idea. Aneurysm, same idea. Increased CSF, we call this hydrocephalus, especially in children. And it could be increased venous pressure because I have congestive heart failure where I am swollen as a balloon. My feet are swollen, my ankles are swollen, my legs are swollen, my belly is swollen, even my neck veins are congested. So these venous congestions can increase the intracranial pressure. Think of it this way. Here is an artery going to the brain. Okay, and here is the skull, which contains the brain, and here is a vein leaving the brain. If this vein is congested, why? Because the heart is so poor, it cannot pump efficiently. So the blood will back up and back up and back up, so the veins will get swollen like this. They are congested, and this can back up into the brain, causing intracranial hypertension. It's the backup pressure, which is the same mechanism behind left-sided heart failure causing pulmonary edema, or right-sided heart failure causing ankle edema. It's the same story. Metabolic disorders such as ammonia encephalopathy caused by liver failure, as in cirrhosis of the liver, or hyponatremia. Remember that sodium problems cause CNS problems. Epilepsy seizures can also raise the intracranial pressure. But hey, what is the normal intracranial pressure? In adults, the normal intracranial pressure should be less than 15 millimeters of mercury in the supine position. If you want to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. This is your brain. Frontal lobe, parietal lobe, occipital lobe, temporal lobe. The tip of the temporal lobe is called the uncus. This was a look from the outside. This is the lateral aspect. But this is the medial aspect. Anterior is here, posterior is there. This is frontal lobe. This is occipital lobe. This is parietal lobe. This is temporal lobe. This is the thick corpus callosum, which connects the right hemisphere with the left hemisphere. What's the name of the bunch of fibers that cross from the right side to the left or from the left to the right? Oh, we call them commissures, and that's why you'll find lots of commissures around this area. Does anyone remember the anterior commissure, the posterior commissure, and the ependymal commissure? See my neuroanatomy playlist to learn more. Above that doozy corpus callosum, we have a gyrus called the cingulate gyrus, and that's important. Next, there are a bunch of vessels here. Oh, and these are branches of the anterior cerebral artery. As you know, the anterior cerebral artery supplies this area of the medial aspect of your cerebrum. So therefore, if I have herniation of the cingulate gyrus, guess who will be destroyed? The anterior cerebral artery or its branches. So I'm gonna lose arterial blood supply to this area. And if you remember the orientation of your motor homunculus, this area is responsible for what? It's responsible for your lower extremities. And if you remember your sensory homunculus, this area is responsible for what? Sensations from the lower extremities as well. So therefore, if I have herniation of the cingulate gyrus, who's gonna suffer? The lower extremity will suffer, and your beautiful bladder will also suffer. And remember that the fibers cross. What does that mean? It means that if the herniation affects the left cingulate gyrus, guess which leg will suffer? The right leg. It will have motor and sensory deficits. Motor symptom means paralysis. We say paresis because it's upper motor neuron. Sensory deficits include loss of sensation. And the bladder will suffer, and this is urinary incontinence. So when you have a patient with loss of motor and sensory innervation to the lower extremity and urinary incontinence, you should suspect anterior cerebral artery stroke or cingulate gyrus herniation. This is another medial aspect of the brain, but this is the right hemisphere now. This is the lovely corpus callosum. This is the anterior commissure, and this is the posterior commissure. Remember that the commissures are made of what? They are made of white matter, not gray matter. These are myelinated fibers. And that's why we can call them anterior white commissure and posterior white commissure. Where is the cingulate gyrus? This is the cingulate gyrus. Let's review the parts of the corpus callosum. This is the rostrum of the corpus callosum. This is the knee. Oh, it's like a knee joint. Oh, you're going like this, like bending my knee. So it's called the genu because genu means knee. Then you have the body of the corpus callosum. Then you have the splenium of the corpus callosum.
Is that what we mean by splenomegaly?
Oh, shut up. This is an inferior view of your brain. The cingulate gyrus is hidden right about here. This is the uncus of the temporal lobe, or the tip of the temporal lobe. This is the midbrain. Remember that the midbrain in front, it looks like a pair of shorts. Each one is called crus cerebri or cerebral peduncle. One on the right, one on the left. After the midbrain, you have the pons. After the pons, you have the medulla. Behind the pons and the medulla, you have the cerebellum. And just like your pharynx, the cerebellum has tonsils too.
Is that what we removed during tonsillectomy?
Dude, growing up, did you have low thyroid hormone levels? Now let's take a coronal suture. Right side is here, left side is here. Anterior is towards you, posterior is away from us somewhere behind us. Here's the right hemisphere, left hemisphere. Look at the corpus callosum connecting the two hemispheres together. So who's gonna connect the right hemisphere to the left hemisphere? Corpus callosum. But who's gonna separate them from one another? The answer is the famous falx cerebri. What's the name of the vein that we find up here? Oh, it's not just a vein, it's a big vein, it's a sinus. Show some respect. This is the superior sagittal sinus. And deep in the abyss here, you'll find inferior sagittal sinus. And what in the world is this falx cerebri? It's a dural fold. It's a fold of the thick dura mater, which literally means your thick, tough mother.
Don't bring my mother into this.
Look at this. This is the nose, so anterior is here, posterior is there. This is the skull. This is the falx cerebri, separating the right hemisphere from the left cerebral hemisphere. This is the tentorium cerebelli, separating the cerebrum above from the cerebellum below. Now on to today's topic, which is brain herniation. We have all kinds of herniation. The first one is called cingulate herniation. Who is herniating? The cingulate gyrus. Where is it herniating? Under the falx cerebri, subfalcine herniation. Then we have central herniation, boop. We have uncal herniation, where the uncus, or the tip of the temporal lobe, is leaving the chat. Then we have transcalvarial. According to Christianity, Christ was crucified at the Calvary. Why was it called Calvary? Because according to tradition, it has skulls buried underneath. So the word calvarium means skull. Transcalvarium is through the skull, piercing its way outwards like this. This is like if open fracture had a cousin. But instead of bone bulging out of the skin, it is brain bulging out of the bone. So anytime you think that your life sucks, just remember that some patients have transcalvarial herniation and stop the whining. Number 5, upward herniation. Number 6, downward herniation. Who is herniating? The tonsils of the cerebellum or surrounding structures. Herniating through what? Through the foramen magnum of the skull. And that's why we can call this foramen magnum herniation. Let's dig deeper. The first one is the cingulate or the subfalcine herniation. All right, I'm compressing what? I am compressing the anterior cerebral artery or its branches. We can call them the paracallosal arteries. Oh, because they are around the corpus callosum. Yup. And when I lose the ACA or its branches, what's going to happen? Leg weakness plus leg sensory deficit plus or minus urinary incontinence. The ACA supplies what? The anterior. It's called the anterior cerebral because it supplies the anterior of your cerebrum. So this will decrease blood flow to the frontal lobe. Moreover, this herniation can obstruct the foramen of Monroe. What is this? It's a foramen between the lateral ventricle and the third ventricle. And if I obstruct this, what's going to happen? CSF will build up, causing hydrocephalus. If I'm a baby, my skull will grow bigger. But if I am an adult, my skull will not grow bigger, but the pressure will rise, giving me morning frontal headache, projectile vomiting, Cushing reflex or Cushing triad, papilledema, decreased cerebral perfusion pressure, and you know the rest of the story. Central herniation is also known as transtentorial herniation. Which tentorium are we talking about? We're talking about the tentorium cerebelli, which separates the cerebrum above from the cerebellum below. Third, which is the most important, is uncal herniation. Professors love to ask about this on the exam, so we will elaborate on this uncal herniation in the next slide. Transcalvarial through the skull. This can happen through fracture or a surgical site, because they make the bone weaker or defective. Upward cerebellar herniation, the cerebellum is being pushed up, versus downward tonsillar herniation, where the tonsils of the cerebellum are being pushed down. Why should I care? Because when they push down, they press on the medulla oblongata. Why should I care? Because the medulla oblongata has 4 vital signs: heart and lungs, get it in, get it out. Heart, cardiovascular center. Lungs, respiratory center. Get it in, swallowing center. Get it out, vomiting center. All of these centers are in the medulla oblongata. If you press on the medulla oblongata, say goodbye to your heart and say goodbye to your lungs. And this can lead to apnea and death. Now let's elaborate on uncal herniation. But we gotta lay down the foundation first, starting with the oculomotor nerve. I have a special video on the oculomotor nerve, which you can find in my neuroanatomy playlist, the best neuroanatomy discussion in the history of mankind. Remember that cranial nerves 1 and 2 leave the forebrain. Cranial nerves 3 and 4 leave the midbrain. 5, 6, 7, 8 are connected to the pons. 9, 10, 11, 12 are connected to the medulla. Okay, so we're talking about oculomotor, which is the third cranial nerve, so that's the midbrain. And here is the midbrain. Anteriorly, it looks like a pair of shorts. Posteriorly, it has 4 balls. What's the name of the pair of shorts? You can call them crus cerebri, or you can call them cerebral peduncles. Cerebral, not cerebellar. What's the name of the 4 balls? We have 2 superior colliculi, and underneath we have 2 inferior colliculi. Superior colliculi for vision, inferior colliculi for hearing. The oculomotor nerve is going to emerge victoriously anteriorly out of the midbrain like this, starting from 2 nuclei. The oculomotor nucleus itself and the Edinger-Westphal nucleus. The oculomotor nucleus is motor. Oh, yeah, it's called oculomotor. It is somatic motor. How about the Edinger-Westphal nucleus? It is parasympathetic motor, so autonomic motor. This is the doozy oculomotor nerve starting in your midbrain, emerging victoriously anteriorly. It will cross by the edge of the tentorium, and that's why transtentorial herniation can affect it. It's also related to the uncus of the temporal lobe. That's why uncal herniation can destroy it. Now here's the oculomotor nerve. It will dig into the cavernous sinus. Not into the cavity of the sinus, but into the wall of the sinus. And we have 2 fibers. One which is somatic motor and one which is autonomic motor. Somatic motor has the red color, autonomic motor has the orange color. These fibers will enter the orbit through the superior orbital fissure. And then the oculomotor will divide into many branches, don't care, but I care about the muscles that the oculomotor supplies. The oculomotor will supply the levator palpebrae superioris to elevate your palpebrum, which is your eyelid. It will supply the superior rectus muscle to help your eye look up. It will supply the inferior rectus muscle to help your eye look down. It will supply the medial rectus muscle to help your eye look in towards your nose. It supplies the inferior oblique muscle, which helps the eye look up. Now let's say that I suffer from transtentorial herniation or uncal herniation. Say goodbye to the oculomotor nerve. Say goodbye to the levator palpebrae superioris. Now I cannot elevate my upper eyelid, so I'll have droopy eyelid, ptosis. Say goodbye to the superior rectus muscle. Now I cannot look up, so I have to look down instead. Say goodbye to your medial rectus muscle. Now I cannot look inwards towards my nose, so instead I'll have to look outwards towards my temple. Say goodbye to the fibers of the Edinger-Westphal nucleus. Say goodbye to these parasympathetic fibers that used to constrict the pupil. So the pupil will not constrict and instead it will dilate. And here is the final result. This patient had right side uncal herniation or transtentorial herniation, and before you know it, the right oculomotor nerve is injured. And when the right oculomotor nerve is injured, the ipsilateral eye, which is the right eye, will suffer. Suffer from what? I cannot elevate the upper eyelid because I lost the levator palpebrae superioris, so I get the opposite, which is ptosis. I lost the superior rectus. I cannot look up, so I have to look down. And I lost the medial rectus. I cannot look in, so I have to look out. There you go. I lost the fibers that supply the pupillary constrictor muscle or the sphincter pupillae muscle, so I cannot constrict the pupil. So it will dilate like this. So anytime you see a patient with unilateral ptosis, mydriasis, down and out, this patient has injury to the ipsilateral, meaning on the same side, oculomotor nerve, which is the 3rd cranial nerve, which could be caused by uncal herniation, transtentorial herniation, or a posterior communicating artery aneurysm. Keep in mind, ptosis mydriasis down and out is oculomotor palsy, but ptosis, meiosis, and hydrosis is Horner syndrome, which is a sympathetic problem. If you want me to make a video on Horner syndrome, please comment below. That's it for the oculomotor. Now let's focus on the cerebral peduncle or the crus cerebri or the pair of shorts. To understand this, we need to refresh the pyramidal tract. If you have not watched my video on the pyramidal versus extrapyramidal tracts yet, there is no hope for you. You can find it in my neuroanatomy playlist. Let's focus on the pyramidal tract, particularly the corticospinal tract. What does cortico mean? Cortex. What does spinal mean? Spinal cord. So it starts in the cortex, ends in the spinal cord. Well, where do I start in the cortex? If you want to understand neuro, you need to draw your line in the sand. In front of this line is motor, behind this line is sensory. So we're going to start in front of the line because this is a motor tract. And then you descend and descend and descend some more. you will descend in the internal capsule, you will descend in the midbrain, you will descend in the pons, you will descend in the medulla, and you will cross in the medulla. So if you started on the right, you will cross in the medulla. Now we are on the left side of history, of the patient. I'll descend on the left side, descend, descend, and descend some more until I end up relaying with the lower motor neuron. Then the lower motor neuron will supply the muscles, let's say the muscles of the upper extremities, lower extremities, and the muscles of the trunk. The question is, when I pass through the internal capsule and the midbrain and the pons and the medulla, where was I when I was in the midbrain? Easy. When you were in the midbrain, you were in the crus cerebri. Oh, the cerebral peduncle? Exactly. The pair of shorts? Particularly. So, if I start on the right cortex, I'm going to descend in the right internal capsule and right cerebral peduncle or crus cerebri of the midbrain, the right part of the basis pontis of the pons, and the right part of the medulla, and in the medulla I'll cross to the opposite side. Now, what does that have to do with uncal herniation? Listen carefully. This is the uncus of the temporal lobe. It will herniate, meaning it's being pushed and pushed and pushed. Which side is this? Oh, this is left uncal herniation. But what side am I pushing? You're pushing the right cerebral peduncle in the right half of the midbrain. Okay, so I have a left uncal herniation pushing the right cerebral peduncle. All right, so these red fibers right here are toast. Now tell me, which part of the patient will suffer? Oh, the left side of the patient will suffer paresis or paralysis. We prefer to say paresis because it's an upper motor neuron lesion. And this lovely phenomenon has blown away many a doctor minds for decades and decades and decades, until a lovely person named Kernowan described what's going on. Listen to me carefully. Forget the uncal herniation for a second. If I told you that a patient in general, after a stroke, suffered from paralysis on the left side of the body, where was the stroke in the brain? Was it in the left half of the brain or the right half of the brain? Easy, medicosis. It will be in the right half of the brain because the patient is suffering symptoms on the left. It's that crisscross action. Right goes to left and left goes to right. We know this. Exactly. So in general, when a patient has a problem in the right hemisphere, the patient suffers problem on the left side of the body. This is typical. However, uncal herniation is the exception to the rule because the patient is having herniation on the left side and suffering motor symptoms on the left side. And this is the Kernohan phenomenon, that you start with a left uncal herniation, pressing on the right cerebral peduncle, causing damage to the right pyramidal tract until the patient suffers symptoms on the left side. And this is one of the few cases where you start with a disease in the left cortex and suffer symptoms in the left half of the body. And this is the genius of Kernowan, that I have uncal herniation on the left side of the brain, pressing on the right crus cerebri in the right half of the midbrain, causing the patient to suffer from left hemiparesis. This is the Kernowan phenomenon. You know those lovely people on YouTube that make spammy videos for medical students with titles like, "How I Memorized Everything in Medical School"? These people are lying through their teeth and they are pieces of melana. If you don't believe me, just ask any one of these doofuses to explain the Kernowan phenomenon to you. Since they memorized everything in medical school through their system, it should be a no-brainer, no pun intended. Look, my dear, there are no secrets to studying. Just get inside your room, close the door behind you, open your textbooks in front of you with a pencil in your hand, and don't leave the room for the next decade or so, and you will emerge victorious, fulfilled, and educated. Look, you're going to die eventually. You might as well learn something and use that thing to help other people. God damn you. Back to uncal herniation, let's review. Let's suppose that I have right uncal herniation. So my right uncus herniated, which will trash the right oculomotor nerve. Now the right oculomotor nerve is history, so the right eye will suffer ptosis, mydriasis, down and out. Sometimes the right uncus herniates and hits the right posterior cerebral artery. And when you hit the right posterior cerebral artery, what's going to happen? You will suffer left homonymous hemianopia, usually with macular sparing. To learn more about this gibberish, I have a video in my neuroanatomy playlist explaining the visual pathway and its defects. Next, my right uncus herniated, so it will press on the other cerebral peduncle on the left side, and the patient will suffer right-sided hemiparesis, which is ipsilateral to the side of the herniation, aka the Kernohan phenomenon. That's why it's medicosis perfectionalis, because medicine makes perfect sense once you understand what the French toast you're talking about. Today we talked about neuroanatomy and neuropathology. Do you want to talk about neuropharmacology? I have a neuropharmacology course on my website, medicosisperfectionalis.com. It will teach you about opiates, anesthetics, stimulants, sedatives and hypnotics, anti-epileptics, antidepressants, antipsychotics, and anti-Parkinsonian medications. It comes with videos, notes, and cases. Download it at medicosisperfectionalis.com. To learn about sympathomimetics, sympatholytics, the adrenergics, the cholinergics, the alphas, the betas, the nicotinics, the muscarinics, and all of this stuff, download my autonomic pharmacology course at medicosisperfectionalis.com. To learn more about strokes, myocardial infarctions, cardiac arrhythmias, ARDS, acute limb ischemia, the toxidromes, and more, download my emergency medicine high yields course at medicosisperfectionalis.com. And to learn about neurosurgery, cardiothoracic surgery, ENT surgery, ophthalmology surgery, general surgery, pre-operative care, post-operative care, etc., I have a surgery high yields course for you. Help me make more videos by supporting the channel. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel if you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.